My name's Michelle Clements. I am a statistician at the MRC Clinical Trials Unit at UCL. I work on clinical trials in neonatal sepsis and paediatric pneumonia in collaboration with people at St George's, University of London, and also with institutes around the world, mainly in Africa and Asia. So sepsis is a substantial cause of neonatal mortality. There are over 3 million cases of sepsis every year with a mortality rate of 10 to 20%, so it is quite a big issue. And this burden isn't distributed evenly around the world. It is much more prevalent in low and middle income countries. And also a particular risk are premature babies. Are very small and they have to be in hospital for a long time, so they're vulnerable to picking up infections. Chlorhexidine gluconate, CHG, is a widely used antiseptic. It is already known to reduce mortality in neonates born in the community when applied to the umbilical cord after birth. So the next question that we were asking was then, could it be useful if applied to the skin of premature babies who are in hospital to stop them getting bugs on the skin, which could then reduce infection rate and then hopefully reduce deaths as well. So before we could go forward to a large trial aiming to reduce mortality, we need to know what treatment regimen to use. And so NeoCHG was developed in order to test 3 different concentrations of chlorhexidine and frequency of application, because we want to make sure that we're treating enough to be effective, but if we treat too much, there's a risk we may cause skin problems in these young vulnerable babies. And so we're wanting to find the correct balance to take forward into a future trial to reduce neonatal mortality. The aim of the NeoCHG trial was to find a treatment regimen to take forward into a large trial. It was a pilot trial conducted in 2 hospitals in Bangladesh and South Africa, recruiting 200 babies approximately. The design was a factorial design. We had 3 different concentrations of chlorhexidine, 0.5%, 1% and 2%. And each baby that was randomized to chlorhexidine then was also randomized to a frequency of high frequency, so that was every working day, or low frequency, which was alternate working days. And they were also randomized to receive emollient or not receive emollient. There was also an additional standard care arm with 16 babies who didn't receive any CHG or any emollient. The inclusion criteria for NeoCHG was babies aged 1 to 6 days of age and between 1 and 2 kilograms at birth. So very small babies where the safety of chlorhexidine was unknown. And so we wanted to test this thoroughly before we move into that larger trial. In NeoCHG, we found no immediate skin problems. We were scoring the baby's skin regularly from baseline until the earliest of day 14 or discharge, and we were scoring that on a score from 0, which was no issues, to 12. And the vast majority of the babies were only scoring scores 0 or 1, and there was 1 instance of a baby scoring 2 and no instances of 3 or above. So that was really positive, showing that chlorhexidine could be used in this vulnerable population. Looking between the arms, however, there was no robust evidence that one particular treatment regimen was better than any of the others, both in terms of skin scores, which were already very low, and in terms of the bacterial load on the skin. So the next steps are to work with the other trial investigators to determine which concentration and frequency regimen to take forward into a future larger trial. We also have another trial running, NeoVTAMR in Malawi, which is looking at larger babies and at labouring mothers, and has also included an additional alternative antiseptic. And so we will be looking to combine both of those 2 results together before we make the eventual decision of which treatment to put into a larger trial, aiming to reduce mortality in neonatal sepsis in low and middle income countries.